Institute for Global Health coming down off the plateau to speak to us today. His area of interest, and the thing he's going to be talking about today, is in healthcare disparities as they're expressed in treatment for brain disorders in Africa. And his credentials academically are impeccable. I highly recommend you look him up and look at some of his papers. But in order not to take from his time, we'll give you Dr. Edwin Trevathan. Thank you.
I like the really brief intros. That was terrific. I can tell you're experienced at this. Well, it's really good to be here. Welcome from Middle Tennessee, which I have to say, I grew up in Nashville. And so when I was a little boy and we would travel around, my father, who was a political scientist, he would teach us when we were young that Tennessee was really 3 states. And what he used to say, my father was always politically incorrect, but my dad would say Tennessee's 3 states. There's Middle Tennessee, Nashville's the capital. There's West Tennessee, Memphis is the capital. And there's East Tennessee. Chattanooga's the capital. And the reason Chattanooga's the capital is because we don't trust those hillbillies in Knoxville. And so when I went to first grade, I think I actually thought that was true, you know. But we didn't come to Chattanooga very much, so this is, I think, one of my first visits to the capital of East Tennessee, as my father would have classified it. But it's a pleasure to be here with you all, and I'm happy to see some people that I've known in the past, physicians whose fathers I know, which is always one of those moments where you realize you're not that young anymore. But it's really great to be here. I think that the excellence and care you all provide here in Chattanooga is a topic of common discussion where I see patients, and we always enjoy sharing patients with you, and I was asked to share that point by some of my colleagues in pediatrics and in neurology. So I don't really have any disclosures other than much of the work I'm going to describe to you, at least the detailed work, is funded by NIH. And some of it is not. That's not. We're looking for some more money, so if you know anybody, you can let me know. And I think another disclosure I'll make up front that this photo is supposed to remind me of is that fundamentally, I think those of us that do work in other countries, especially low and middle income countries, fundamentally we're really in the relationship business, and we don't talk about that very much. And you can't get anything done without relationships, and typically relationships with people on the ground in communities. And so this is a photograph of a man that I've come to know in Kano, Nigeria, who is the leader of this area of town unofficially, and you can't get anything done without working with this guy. And so Aminu and I have become good friends over the last couple of years, and I always make a point of seeing him. And I have a couple of house outfits you may see, you'll see what that means in a minute, that actually my friend Aminu gave to me. So I think that if journals were of sufficient length, we could write about our relationships that actually help us do the work to help people, because that's really the key. Now, what I'd like to do is to give you sort of a big picture concept of maybe what's going on, at least in global health at Vanderbilt, because I'm asked to do that, and then just have us drill down on one area that I think illustrate some general global issues, actually, which is really disparities in care, which we experience here in Tennessee and in North Georgia, as all of you know. But so there are times when we can take what we learn internationally, bring it back home. We refer to that sometimes as reverse innovation. That's a whole nother discussion. But I think that sometimes some of the things we learn when we're working with our partners internationally, sometimes they have some really great ideas that we could think of using ourselves to address our own health disparities. But this is a not exactly up-to-date sort of laundry list of all the places where faculty are working in Vanderbilt on various sorts of projects. And so my job of directing global health is really literally herding cats. You know, there's just no way to tell people what to do, and we don't really want to. Most of this is spontaneous. We're now working on a strategic plan to help us sort of coordinate and then better enhance what we're doing internationally and give more people more opportunities to work internationally. And this is just a slide that I finally quit updating because nobody can read it, but gives you an idea of the breadth of different things that we're doing. And I show this primarily because of this, is I think that very often in global health, we project this unintended idea that you sort of have to do infectious diseases, or you have to do maternal child care, or you have to do a sort of a narrow group of clinical or investigative areas in order to make a difference. And I would say that if I could channel some of the health leaders that I know in different parts of the world, they would want to emphasize that yes, HIV is a huge problem, so is tuberculosis, so are all these other, many of them preventable infectious diseases. But there's this wave of chronic disease that's hitting all of these low middle income countries around the world as they start to become more like us. And so one of the greatest needs they have are in areas like oncology, urology, dermatology. In fact, you can't find a field that they don't have a need for and have innovative ways to deliver the care to people that have those problems using innovative methods. And then sometimes that partnership, as we learn new things, can, I think, benefit us through reverse innovation. You know, I'm here to tell you that looks like a lot of money, but we don't ever have enough to do the work we're trying to do. So one of the real challenges in global health is matching needs in other countries, working with our partnerships, the people we have relationships, matching their needs to expertise of people here in the U.S., and then somebody that's willing to pay for it. And I think that we could actually do a lot more, not only us at Vanderbilt, but a lot of places, and probably a lot of you, if there were more funding opportunities in this area. We try our best to sort of look at our global health work through the lens of the people that are living in these countries. And I know that I don't have to review with this group this rather dark past of colonialism that still haunts us somewhat in many of these countries, and this problem we have still, to some degree, with people from wealthy places going to poor countries and basically telling them what we think the solution to their problems are. And so one of the core issues that we try to abide by is really working in partnership with local folks to try to find out what they need, matching our expertise. And we focus very narrowly sometimes to really solve problems, but really think of it from a point of view of global impact, and then how can we sustain it, and then mutual benefit. It's got to be something, at least for our funders in the U.S., that actually is of some interest to the United States, or if it's a European agency in Europe, but that we've got to make sure that there's always benefit to the local people. So we work at the individual level, often it's relational, and then we try to facilitate capacity building at the organizational levels in these countries. So one of our rules that we try not to violate is we never work in a country in which we go in and we do work, but we are not connected with the local medical school, the local hospitals, the Ministry of Health, and even down to the man I was shaking hands with on the title slide, the local leaders and the people. Because if we don't push it out to the organizational level and the local leaders, it's not sustainable, and it doesn't really help our relationships. Then we really try to figure out, one reason working with the Ministry of Health early on is that having partnerships with the Ministry of Health then helps you scale up whatever you find that can be beneficial to people, so that you actually can make a difference with research findings or with new clinical innovations. Failure to do that just produces a paper in some journal with no impact whatsoever. And one thing I'll just mention to you just very briefly is that one of the things I think is still the case about the U.S. and some of the European countries as well is that we are investing in educating local physicians in other communities and places like Nigeria and South Africa, Tanzania, Vietnam. We're helping train them through partnerships so that then they start doing their own research, developing their own solutions to their own problems. And so the NIH has helped us do that at Vanderbilt for really a long time. And so we've trained now, I think it's close to 700 trainees in 33 countries, and NIH has really funded this quite a bit. But one of the things that's really been exciting is that these trainees have then started getting their own funding and are actually doing their own research and training their next generation. So in a sense, there's a whole nother discussion we could have at some point about global health diplomacy, which is another topic, but I'll tell you this is it. In order to build relationships with other countries that we want to be our friends, nothing works better than investing in training and building the next generation of leaders. And so I think that's something that we can do more of in terms of how we frame some of what we do as global health professionals. Let's see if I can get this to move on. This is more of that. All right. Real briefly, just to let you know about one of our larger projects, and I'm mentioning this primarily because I think that sadly PEPFAR, or our large program in the United States that's funded through the State Department and through the U.S. CDC, it's hanging on by a thread. It is, I think, over time going to be at risk of being cut. All these programs are, but really nothing's done more good probably than PEPFAR in terms of improving the health of many of the countries in sub-Saharan Africa by actually helping identify people with HIV through screening, getting them on treatment, and preventing maternal-child transmission and other transmission. And so one of our largest projects is in Mozambique. It's a Portuguese-speaking country in the south of the African continent. And to give you an idea of the scope of this thing is there are about 2,000 employees in Mozambique that work on this project. So this is an enormous effort. But in Mozambique, the incidence of HIV has reduced the incidence by 10%, reduced maternal child transmission rates, not to zero, but really quite low. And you can see some of the other areas where there's really been an impact with this program, largely due to people that are from Mozambique, living in Mozambique, that our colleagues that do this work at Vanderbilt have trained and are supervising and helping them do the work. But the HIV problem in Africa is going to require more PEPFAR funding and funding from World Bank and others for many years into the future. Over 1 million people have been screened, and those that are in need of ART are mostly getting on the drug. You can see the growth in people enrolled in ART or medication for HIV here. One of the areas that's really a challenge and this, I think, is an area for future research. It's been more difficult to identify children and get them enrolled in therapy, and Bill Wester, who runs this project, is focusing on that problem now. I mentioned our relationships, but we have scores of, individual relationships, but relationships with over 30 major big organizations, so that when we report what we're doing, it's really a team. It's almost never, or really never, Vanderbilt. So let me drill down and look a bit at brain disorders in general, and I'm using that term, but you'll see why in just a minute, because all of these disorders that we think of as substance abuse, psychiatry, and neurology in the United States, in a lot of these low middle income countries, comes together and subsumed under what the World Health Organization calls mental health. We usually use the term brain disorders around here because if we say mental health, we're thinking people aren't talking about stroke and epilepsy. But all of these disorders are included in this category. Now, it's a huge problem, and it illustrates my point that you don't have to be an infectious disease specialist or a maternal child health specialist to make a difference in the world. And so this is almost 20% of the global burden of disease. And in addition to that, what makes this worse and sometimes difficult problems to solve are the stigma and absolute overt violation of human rights that compounds this problem. And in general, if you take all of these common brain disorders throughout the poor world, low middle income countries, about 75% of these people are not treated. And I don't mean they're not treated optimally or by a skilled person. I mean they're not treated, period, full stop. So what that does, if you do the math for this, when you realize for almost all of these disorders, the majority of people with these disorders live in low and middle income countries. Whether you're talking about depression, epilepsy, I could go down the list, worldwide, less than half of people with these class of problems are treated at all. It's just mind-boggling. So, I was at the American Neurological Association meeting speaking back in the fall, and one of the people in the audience made the point that we have these huge meetings in the United States and Europe where we talk about half of the world's population, or even less than that, the people that are not responding to the treatment that's available, whereas the other half of the world that has, of people that have these disorders, their problem is they don't even get the first shot, at treatment. So this is really where, in general, a lot of the work we're doing in global health now is focusing, is how do we access basic care to people that don't have it. So for those of you who have done work in epilepsy, you may know about this global campaign against epilepsy, Out of the Shadows. I was relatively young when this started, and we thought we could solve this problem. This was in July of 1997. This in BMJs became a real priority around that time. And a lot of what we were thinking at that time was that we need to go train physicians. We were thinking about this problem as Westerners. We need to go train more physicians. We train more physicians, and we just get more physicians from rich countries to go take care of this problem. We can solve this problem. And the short story over the last 25, 30 years is that does not work for a lot of reasons in these countries. And a lot of it's got to do with the fact we train people to be like us. They can't practice in these countries, and so then they come here, and then the problem is still really no different. And so we've had this huge attention to this problem with really no change whatsoever. These are some children that we've just screened for epilepsy at the time they're dancing. I don't know, I don't think the screening made them happy, but I thought the picture was great. But we've just in the last few years, there's been an effort at WHO to really look at So how should we address this treatment gap problem in brain disorders? They use the term mental health for all these disorders. And the WHO has made some very bold recommendations based primarily on the fact that, one, what we did before didn't work, and when we use what's called task-shifted care, so we take at the point of care, we, instead of having a physician or even a nurse practitioner or PA do the care, we train these community health workers that frankly do not have the training background of an LPN in the U.S. We train these community health workers to do the diagnosis and to do the care. Now, the basis of the WHO recommendation is not that that's ever been proven to be helpful. It hasn't in any of these disorders. What their recommendation is based on is that from a resource perspective, they see this as the only reasonable alternative, and it's been effective in HIV, okay? Now, all of us that are clinicians realize there's a world of difference between diagnosing someone with HIV as you line them up and you check their status with a laboratory test if they're in a high-risk area or they're in a high-risk group. That's really different. That's a laboratory diagnosis. Try doing something like that with epilepsy in places where there's no EEG. How about doing that with subtle stroke syndromes or with depression or bipolar? I mean, then you suddenly realize this is a whole different world. And so one of the directions that we're taking now is what can we do to test the hypothesis that community health workers can be trained and empowered to do this kind of work. Can this technique or strategy that WHO has recommended, can it be effective? So we've drilled down to childhood epilepsy now, and we're working in northern Nigeria. Reason for northern Nigeria, it's the most densely populated, largest population basically in sub-Saharan Africa. Half the people that live there are under the age of 17. So there's a huge number of children. And in general, though, 80% of the world's children with epilepsy live in these low and middle income countries. The treatment gap is 65 to 90%, and therefore more than half of the world's children with epilepsy are not receiving treatment. And so the World Health Organization, in their mental health gap intervention guide that was published pretty recently, have some pretty general concepts of how this task-shifted care, training community health workers to do the work can work, but it is so lacking in detail that I think if anybody taking care of people with epilepsy were to read it would realize that you can't really do it from the guidelines, that it's more aspirational than anything else. So what we've done is we've decided to do this, look at this in northern Nigeria. Now we have quite a few other projects in northern Nigeria. We've had asthma projects and at Vanderbilt, asthma, HIV, preventing maternal transmission, big project there. We've got renal disease studies. We have a big clinical trial now going on of prevention of stroke among children with sickle cell disease. So there's a platform of work in this area, even though it's very, very poor. And we have some great relationships with some of the best clinicians I've ever worked with. And so it's a good place to go. Now, another thing that is important for all of us that take care of patients with these brain disorders, broadly speaking, is that we make the diagnosis often with just history. And so we have to develop the tools that we use in the local language. So if you look up Niger in Nigeria, you will see that Niger is a French-speaking country and Nigeria is an English-speaking country. And if you're talking to physicians, that's true. However, that is not what probably 80 to 90% of the local people speak, because when the colonists, cut up these countries into little pieces, they cut tribe areas in half. or in thirds in order to deal with the population. And that's exactly what happened in Nigeria. So if you look at that yellow densely, I don't have a pointer, but if you look at that area that's yellow, that's an area where almost everybody speaks Hausa. Hausa is actually the most commonly spoken language in West Africa. Probably 90 million people speak Hausa. And if you're not doing epilepsy and depression, and I could go on, diagnosis and management in Hausa, you can only take care of about 5% of the people. So we chose northern Nigeria because it's sort of the seat of Hausa, which that belt of Hausa language spreads way to the west into northern Ghana and Burkina Faso and other countries, and it goes way to the east into Chad and South Sudan, northern Cameroon, a large area to the west. So if we can get this to work in Hausa, we're doing it in the local language and most commonly spoken language in West Africa. And that's really one of our reasons for choosing this place. Now, we also have to have methods of diagnosis that don't rely on EEG. So if you look at a population of about 20 million people, what I was told initially is there were 3 EEG machines for about 20 million people, but actually only one of them works most of the time. And so Dr. Ireland's laughing over here. So, you know, if Dr. Ireland was in northern Nigeria, he could lock up the use of the only EEG machine all day, every day, and need more, right? So we can't solve this problem by getting more EEG. So we have to figure out how we diagnose with low resources with EEG. So Kano, which is where the arrow is the second largest city in Nigeria. That's where we're really focusing on with a lot of these projects. And to give you an idea of the lay of the land, one reason we've chosen Kano is that the British left not a well-funded system, but as you might guess, a very well-organized system, okay? So they have about 250 primary health care centers, 167 that are relatively complete, meaning they actually have a full-time community health worker. Then they have about 5 to 10 secondary hospitals. Those hospitals have a physician, one. And then they have really 2, depending how you count them, as many as 4 tertiary care hospitals. And these hospitals have a lot of physicians, look much more like Erlanger in their system. So this is the way their system works. So what we did was, working with the Ministry of Health, we did a randomized selection of 8 of really 167 primary health care centers. And we did the randomized selection so that these primary health care centers that each serve a local community would be representative of the larger whole. And so that'd be like randomly selecting practices, you know, in East Tennessee, and then having everyone say yes. That's why relationships are important. But that's the system that we have developed. So within those primary health care centers and these other hospitals where we're working, we've trained the people that work there. And we're in the process now of mapping the childhood epilepsy treatment gap with the idea, and I don't have those data to show to you today, but this is a technique we're using across these different disciplines where we actually do surveillance in communities and we map not only where epilepsy is, but where there are higher pockets of untreated people so that resources can be better focused. And then we're looking at developing innovative methods for having these community health workers manage epilepsy in these low resource areas. So we've got the education of these community health workers that have roughly an 8th grade education if you look at compared to our system. And then we've developed an epilepsy screening and diagnosis tool. And we're now piloting this protocol with the community health workers. And if NIH is good to us, we'll have funded a randomized control clinical trial comparing epilepsy outcomes when physicians manage the patients versus when our trained community health workers manage them. So first, the educational program. So how do you educate a bunch of people who really had never heard of the brain, who all think that epilepsy is caused by evil spirits, okay? But they're smart. They're smart people, learn quickly, and are dedicated to their local community. So we've developed a program using a flipped classroom methodology, and then how do you take that to scale? How do you educate thousands of those people? So that's sort of the problem we're working on now. So we've got a flipped classroom methodology where we have lectures that are recorded that are like 15 minutes, and then that's followed with these group activities that reinforce the lecture. And so all our community health workers have all these lectures and all these notes on these tablets they carry around with them. And that program has now been tested, and it works at least in our first 18 or so community health workers. But here's an example of a lecture. Now, I'm not recommending you look at it, but imagine a lecture that's 15 minutes on Introduction to the Human Brain, and you go from that within a month to getting down to the nuances of how do you recognize juvenile myoclonic epilepsy without an EEG. And so that's basically what we've done with these folks. So we have lectures on comorbidities, vascular anatomy, basic neurophysiology, non-epileptic seizures, and many more. We're up to about 35 lectures and group sessions. And so we initially enrolled 20 of these community health workers. Now remember, these are randomly selected people, okay, from the community that work in these primary health care centers. And we have pretty high level requirements. 18 of the 20 passed the course, and I think the 2 who didn't was really more family issues than it was academic. And they all have certificates now from Vanderbilt and Aminu Kano Teaching Hospital in epilepsy for community health workers. And again, just to point out the relationship, here's the embarrassing photos of me in those house suits from my friend that I have to wear to show my friendship with him. I want to just show you this photo of these little girls in the top left-hand corner. Now, one of the things, if you do a lot of work in sub-Saharan Africa, you've seen, or if you go, you will see if you know to look for it. When children are severely disabled, very often the way the community deals with that, with no resources, is that another family member is assigned to that person 24/7. They walk around with them, they bathe them, they take care of them, when they fall and they hurt themselves, they manage them. And so it takes that person basically out of the workforce or out of school. So this photograph, you can tell which girl's the normal one and which one's got the problem. The girl who looks encephalopathic is, in fact, she was picked up in our screening, is having previously undiagnosed Lennox-Gastaut syndrome and untreated. And this, bright-eyed little girl's job in life is to walk around with her sister. So here's our epilepsy screening tool. I'm not going to go over it in a lot of detail, but it should be published pretty soon. We're presenting it at a meeting a month from today, actually. But there are 3 screening questions. Has your child ever had a seizure, fit, or convulsion? Again, this is in Hausa. If yes, has he or she had 2 or more episodes? If yes, have any of the episodes been without a fever? And then, if yes, have these episodes have been characterized by altered awareness, inability to respond, or loss of consciousness? Has your child ever had episodes of altered awareness? And then, does your child have clusters of sudden head drops or nodding? Nodding syndrome being an African syndrome we don't have here now that resembles infantile spasms, actually, in older children. So we have to ask about that. That's all. The clusters of head drops would be asking about atonic seizures or infantile spasms. And then if you ask, does your child also have extension and elevation of his or her arms? Like that. And we have videos on the tablets to illustrate how that works. If yes, do these episodes result in sudden or unexplained falls? Atonic, tonic seizures. So if they're no to all these questions, they're excluded. Go to the next kid. If any of those questions are yes, then there's this long list of other questions that are asked. And these questions are designed primarily to distinguish between focal onset and primary generalized seizures. And we would love to be able to get to where we can do better than that, but that's pretty much where we are now. And these questionnaires are now used in a screening system by these community health workers who've been trained in epilepsy. So we've recently validated the screening tool, and the screening initially, we've now screened over 10,000 children, but the initial validation was with the first 765, and there are 82 screened positive, and then 63 of the 683 who screened negative were randomly selected for evaluation, and these evaluations were done by physicians. The screening was done by the community health workers. In fact, these physicians are epileptologists. And so for those of you who know about validation and sensitivity, specificity, ROC curves and so forth, I'm not going to go over this in a lot of detail, but just this, we really did well with this screening tool thus far. I mean, the sensitivity and the specificity, predictive value positive, are really good. In fact, I would say if you just lined up all these kids and gave them EEGs, you could not do this well. I can't prove that because we're not going to do that study, but those of us that do clinical practice, I think you can see that's probably the case. And so that's in terms of epilepsy, no epilepsy, that's worked well. And then among those who screen positive, if the screening questionnaire performed by the community health worker says that this is generalized, what's the predictive value of that for being generalized? If the screening questionnaire says it's focal onset, what's the predictive value of the epileptologist saying it's focal onset? So when we look at that, those data are also quite helpful. And this is one of the reasons we focused on this quite a bit, no pun intended, is that the only drugs available over there are phenobarbital, carbamazepine, and valproate. And valproate is the most expensive. And they have no access to drug levels. And they have very little access to routine blood tests like CBCs. We can do CBCs, but not very often. And so we have to be able to do really a great job with excluding epilepsy syndromes that can be exacerbated, for example, by carbamazepine, which is one of the reasons why I will put our community health workers up. We may figure this out in a clinical trial, but I will be happy to put them up against any group of neurology residents in terms of picking up juvenile myoclonic epilepsy from a history. They are really good at it, but they have no EEG, no access at all. And so that's really the way the systems work. Now, the trial that we are proposing is a cluster randomized controlled trial. Briefly, what that is for those of you that aren't into nuances of clinical trials is, as in most clinical trials, we randomize people. The person comes in, they have the disorder, they get randomized to placebo or treatment A versus treatment B, and you compare. Cluster randomized controlled trials, what we are doing, at least in this study, is we aren't randomizing people. We are randomizing communities. Again, back to the relationship issue with the local leaders and the community workers. but we will be randomizing 120 communities and their health centers. And some communities, when they're screened for epilepsy and they aren't diagnosed, and oh, by the way, in this population, depending on what part of town we're in, the treatment gap is 60% to over 90%. So there are a lot of these kids that aren't treated. We've estimated in our catchment area there are about 30,000 untreated children. So even if Dr. Ireland went there to live, you couldn't address this problem. So what we do is we randomly select 120 of these communities, community health centers, and then we randomize half the communities to the task-shifted care with the community health workers, and then half to being cared for by physicians, and then look at outcomes as assessed by blinded neurologists that examine the kids every few months, and they have no idea whether they're receiving care from a physician or a community health worker. And this is the detail of the protocol for the intervention, or what the community health workers do with epilepsy. And they do the screening, and then they evaluate the patient. And we have some rules where if they have a certain finding, that they automatically refer to a physician. Like if they want to use valproate, the physician has to say yes. If they think that there's a progressive neurological deficit, then that gets referred to a physician. But otherwise, they're pretty much managing these kids on their own with routine scheduled follow-ups and blinded evaluations by neurologists. And we now have over 30 children that are in this pilot of this task-shifted care, and things are going actually quite well. We're serving as sort of the unblinded, where we see all the data, coordinating center at Vanderbilt. The data are uploaded electronically to us every day. So the system seems to work. So our hope is to be able to get these data set up to where we can then launch this randomized controlled trial. That would then be the first time through a cluster randomized controlled trial, we've been able to show whether or not this approach the World Health Organization has recommended actually works for any of these brain disorders. And we're already planning, not me personally very much, but we're planning doing the same thing with depression and some of the other major mental health or brain disorders. Now, one thing I want to show you briefly that's right off the press, and if I'd known there was another Epidemic Intelligence Service officer alum in the room, I would have definitely showed this and given you more slides. So sorry, I can tell you more later. But this is sort of classic CDC style public health applied to a problem. And we have a young child neurologist in Kano who I'm mentoring, and he has a NIH grant with me to sort of just get him launched on his research. And so he's chosen to do population-based surveillance of status epilepticus, focusing on children in Kano. And the question really is, how often does this happen? What's the incidence? What are the outcomes? What's the mortality and the morbidity? And what can we do at a system, and then eventually to figure out what can we do at a system-wide sort of level to make improvements in outcomes, if any are needed. Now, we were looking for some trying to figure out what would be the possible mortality associated with childhood status epilepticus in Kano. And there's no good data on population-based incidence or mortality from status epilepticus in children or adults in sub-Saharan Africa. So we looked around and we sort of found some data from rural India, and we looked at what we have here in the U.S. Mortalities per episode is less than, it's 1% or less. In India, it's about 2 to 3% mortality risk per episode for children. And sometimes they're measuring data weeks to months after the event, after children go home from the hospital, including that in short-term mortality. So we looked at that and we said, okay, it's worse in Kano just because everything's worse in Kano, other than the delightful people. And so let's say it's 2 to 3%. And let's suppose the incidence is relatively similar to what we have here. So we set up this surveillance system. I won't go over it, but we sampled 8 to 9 of the community health centers. And then we have 4 of the secondary hospitals, and then the 3 major tertiary care centers, all in our catchment area for our surveillance. And we have rapid collection and response of the data. So we estimated that if we did this surveillance for a year with this sample of healthcare facilities, we would pick up 100 cases, and the mortality would be 2%. So anybody want to guess what we found in the first 3 months? So we thought we would get 100 in a year, 2% would die. Here it is. First 3 months, this is data, and I've left this off the slide. This is data October 1, 2018 through December 31st, 2018, and we had all these data that hit January the 18th. So for those that know surveillance data, you know that's very timely. So the system's working. But what actually required me to go to Nigeria to reassure my colleagues who were almost depressed was this. 300 plus cases in 3 months with this collection of data, not 100 in a year. And the mortality rate is 21.1%, not 2%. And in fact, if you look at the kids under 12, the mortality rates are even higher than that. And so now we're trying to figure out, oh my goodness, the mortality is 10 times what we thought, and the incidence is, I don't know yet, it's many times more than we thought, and what's going on? So now we're setting up studies. Now we're reporting this to the Ministry of Health, we're reporting this to NIH, we're working with local people to figure out why is this happening? Well, they don't have an ambulance system, they don't have an emergency medicine system, they don't always have the drugs available in emergency rooms, they don't have the availability of basic things to ventilate small children, which we think could impact some of what's going on in the younger age groups. And so, you know, this is a huge problem, and now I think Umar Sabo, this might be his career, is to figure out what's going on. Is this a problem everywhere? And here's the sad part about it, and why my friends are so disturbed by this, and why we are so feeling like this is a priority we have to work on, is that if you have to pick a place almost anywhere in sub-Saharan Africa that we think probably is doing this well, outside of South Africa, it would be Kano. They have more neurologists. They have record-keeping systems that allow us to get rapid data. Their physicians and community health workers are very well educated and trained. And yet they've got a 20, so of each episode of status epilepticus, there's a 21.1% chance of death. So this is an example of a problem that you find when you look. But if you look on the list of big problems in sub-Saharan Africa, you will not see status epilepticus. So I think that if you, no matter what field you're in, there probably is something there for you to work on. So just in brief, we think that task-shifting community health extension workers has promise, but I don't know how to scale this up. I don't know how, if we get the community health workers to do as well as the physicians, which I think we could possibly. I know that with 4 neurologists, we can supervise 120 community health workers. But to scale this up, we would have to have a method of those same neurologists supervising maybe 2,000 or 3,000 community health workers. How do we do that? So there's a lot of things that we don't know how to do yet. There's plenty of research opportunities, especially in areas of implementation science. All of these efforts we do have to emphasize cultural humility and competence and language skills and working in the local language. And I have to say, the one thing that I've learned repeatedly is we cannot underestimate the motivation and the natural intellectual ability of some of these lower level workers in health in some of these countries. And I'm convinced that a lot of the community health workers I work with, if they were in the U.S., they'd be in medical school, or chief of surgery somewhere or something. These are very, very gifted, hard-working people, and I think technology also has an opportunity to help us. So I won't go through everybody, but there's the stuff I've shown you about just the epilepsy treatment gap. There's a group of us at Vanderbilt, St. Louis University, where I used to work. The core is really at Aminu Kano Teaching Hospital, including our community health workers. A group of my friends have signed up for an unpaid lot of work advising us. They're now in the Bridge Advisory Panel here, and we appreciate the funding from NIH that allows us to do this work. Whoops, oh, I hit the wrong button. So thanks a lot.
Thank you, Dr. Nathan. I think maybe we'll take a couple of questions.
Yeah.